So next, we're going to transition from the diagnostic approach to actually a combined approach for both diagnosis and treatment at the same time. This is going to be presented by Dr. Tsai. Dr. Tsai journey to thoracic surgery started actually in New Jersey, similar to myself. Trained at Robert Wood Johnson. He did his CT fellowship in Pittsburgh, where he actually met my boss, Dr. Pettiford, and Dr. Pettiford emphasized that Dr. Tsai is a leader, not only just a master surgeon, but an innovator and a great entrepreneur. So we're happy to have him here today, and he's going to talk to us about, do we not have his presentation loaded? But it's going to be about SABRE, which is the combination of robotic bronchoscopy combined with robotic resection. So thanks, Dr. Tsai, for coming.
All right. Well, thank you for that introduction, Dr. Dozier. And again, I definitely want to extend a heartfelt gratitude and appreciation to my colleague as well for inviting me today. So today, my talk is on this new procedure. It's not new anymore, but when I started evolving it, I wanted to have this fancy, sexy name for it, so I figured I'd call it SABRE. The reason I called it SABRE was because that's the name of my Brazilian Jiu-Jitsu Academy, and I kind of want to, give homage to my my roots there as well. So SABRE stands for me, Single Anesthetic Bronchoscopic Robotic Event. For me, this is exactly why it's important. And when I found out that today's conference was about patient advocacy in cancer treatment or in cancer diagnosis, I really feel like this was a very important segue to comment on, especially to this very motivated crowd. So this is the problem with lung cancer. We know that lung cancer is the #1 cancer globally, and it kills the most number of people in the entire world. Every 2.5 minutes, someone is going to be diagnosed with lung cancer, and every 3.5 minutes, someone in the United States dies from lung cancer. About 150 to 160,000 new cases of cancer per year. So this is a very, very deadly cancer. And unfortunately, over the past several years and decades, we haven't really been able to move the needle on the survivability of lung cancer. And hopefully, if we pursue avenues as our interventional pulmonologists and our thoracic surgeons have described, I really am hopeful that we can actually make something better, especially for these lung cancer patients. So if you look at this, what happens, of course, no duh, the later we diagnose the lung cancer by stage, the lower their survivability is. And you can see that in most patients in this country, they're diagnosed late stage. Up to 57% of patients are diagnosed when they have metastatic disease. And the real reason why is because the majority of these lung cancer patients, they don't really present with a lot of symptoms. And so over 85% of patients in this country are diagnosed with lung cancer incidentally, meaning they went to the ER, they had gallbladder pain, they get a CT scan, and by the way, besides gallbladder disease, you have a nodule at the bottom right lower nodule, at which time either hopefully they get workup for it, or a lot of times these patients are lost to follow-up, and I think that's the biggest problem here. As alluded to before, there were certain diagnostic options that we had back in the past. #1 was the CT-guided biopsy, though we call it transthoracic needle aspiration. As you can see the data there, the diagnostic yield is really high. It's about 90% in many centers that actually have very good interventional radiologists. But the biggest problem with the CT-guided needle or biopsy is the fact that the pneumothorax rate was extremely high. So the pneumothorax rate can be 20 to 30%. And that poses a problem for these patients because now they thought they were going in for a simple biopsy, and all of a sudden they're getting a chest tube in, they're getting admitted, they're staying in the hospital for several days. And not only is that a severe complication for these patients, it becomes a big money loser for those hospitals. So if you look at our data, we know a CT-guided biopsy in our hospital pays about $700. But if these patients get admitted to the hospital, then there's a significant loss because that reimbursement is not generated for those admissions. So the hospitals end up losing a lot of money from it. So then what happened was we started having this new development in electromagnetic bronchoscopies, what we used to know as superdimensional bronchoscopy. And, everyone was touting this as the greatest sort of, thing since sliced bread. But if you actually look at the data and tease out the data, the diagnostic value or diagnostic yield for a superdimensional bronchoscopy, it was still much lower than a CT-guided biopsy. We've all been in that situation before where we're in the OR, you've taken this patient to the operating room, you've administered general anesthesia, and you're sitting there digging away at hours trying to prove that this nodule is a cancer, and all you can do is get the pathologist to say, I still don't see anything that's diagnostic. That's a lot of anxiety provoking sentiment to us because we want to have a responsibility to this patient that when we bring you into the operating room and we give you general anesthesia, I want to come out of this operating room giving you a diagnosis. And nothing is more anxiety provoking than, of course, not being able to do that. So the problem with transthoracic needle biopsies is, it can't go everywhere in the lung. You have problems with the nodule is too centrally located. So the interventional radiologist will say, no, the heart's in the way, the subclavian artery's in the way, the diaphragm's in the way. And again, the biggest problem is the fact that it can't also stage the patient at the same time. So when our interventional pulmonologist colleagues go in for these robotic navigation bronchoscopies, they can also do an endobronchial ultrasound at the same time to look at the mediastinal lymph nodes, and now you have diagnosis and staging all in one setting. So this is the reason why the electromagnetic bronchoscopy wasn't a very stable platform and had very low yields. So this is the superdimensional bronchoscopy. As you can see, this is your workforce around this. You have literally 3 or 4 people standing around the patient, and you have the bronchoscopist holding this handheld camera, and you can see any sort of movement changes the position of the tip of the camera. And so in order to really get a good diagnosis, especially the farther and farther these nodules go out, you really need to make sure that that hand is immobile. But unfortunately, because of human factors, that hand will always be moving, at which time the tip of the camera can also change. Even 1 millimeter will change the angulation at which you insert your camera. And that's the reason why these navigation bronchoscopes, handheld navigation bronchoscopes, were so inaccurate, because it relied on human factors and not so much the robotic component. The next slide I'm going to show you, it's a little bit gimmicky, a little bit sort of, commercially, but it does hopefully give the room an idea of why we think, or why I know, and everyone else knows that does this, why the robotic navigation bronchoscopy system is better. So, there we go.
Conventional bronchoscopes are controlled by the human hand. They can lack the stability and maneuverability provided by a robotic system, and they may not provide the precision needed for a lung nodule biopsy. We designed iron to perform precise and accurate biopsies deep in the peripheral lung. Physicians can repeatedly biopsy the same target, while systematically change the sample location in the same area. Robotic distal tip articulation allows physicians to aim the catheter at small targets, even when located outside the airways. Iron's Flexition biopsy needle is flexible and allows it to advance through tight catheter bands and still deploy in a straight path into the target location. Iron's shape sensor provides precise positioning and orientation information. This enables precise control of catheter positioning and interaction between biopsy tool, tissue, and the catheter itself. The user can precisely steer the biopsy needle into different areas of the target. If real-time confirmation of a representative tissue sample is available during the procedure, the user can systematically redirect subsequent biopsy attempts into the confirmed target area. We refer to this approach as cloud biopsy. ION is designed to provide the precision needed for lung nodule biopsies in all areas of the lung. I'm eager to see the system used in a clinical setting and provide physicians with a new biopsy option.
Perfect. So as we, ignore all that, enthralling music and stuff like that, you can truly tell that what this robotic platform does, it gives our proceduralists an ability to maintain stillness and stability, and all the while be able to navigate all the way out to the periphery of the lung, and quite honestly, anywhere else in the lung, as our interventional pulmonologist referred to. So when I started this procedure, I was, one of the first surgeons in the Pacific Northwest to really start robotic navigation bronchoscopies. And, back then, it was very hard for me to get my interventional pulmonologist to jump onto this. And I don't know why, but I do think there's a, significant cultural change now. And so I was kind of stuck here by myself as a thoracic surgeon trying to figure out this robot that this hospital purchased for me. And these are one of my earlier cases in terms of what I was trying to do to navigate, no pun intended, or how I evolved my thoracic program when I started combining technologies. So this is a 69-year-old male. He was actually the father of one of our intensive care nurses, and he had a history of multiple heart issues, but he ultimately has a history of COPD also. He was a big-time smoker, and again, he was being seen because of the fact that he had this chronic cough, and he had the workup, which of course includes a chest X-ray and finally a CT scan. So this is what the CT scan showed us, and ultimately he ended up with the CT PET scan. So there was a 4-centimeter PET avid lung mass in the right upper lobe. There's no one in this room that's going to deny that this is a lung cancer until proven otherwise. And so this patient needs to not only get a diagnosis, but they need to get staging, and they need to get the proper surgical treatment or medical oncology treatment. But the other issue for this patient was not only did he have this 4-centimeter right upper lobe mass on the left upper lobe, there's also a spiculated lesion that made us kind of think to ourselves, I wonder what's going on here. So I called the interventional radiologist, asked, hey, can you guys try to biopsy this thing? And the biggest reason why they didn't want to biopsy it was because of the fact that, as you can see here, this patient has significant emphysema of the left upper lobe. So therefore, this fits this patient into that category of developing a high rate of a pneumothorax, at which time, if the patient's admitted, then of course he doesn't get his other procedures for his right upper lobe. So they really kind of hemmed and hawed and says, I really not like to do this. Can you do something else? So I was like, well, now I got this new robot in my OR. Let me see what I can do. So this, again, is one of my very first cases. And so I really want to get a crack at, can I get a diagnosis for the right upper lobe lesion? Well, that was a really easy nodule to biopsy. If anyone in this room, misses a 4-centimeter lesion on your robotic navigation bronchoscopy, go back, pull out your Nintendo or something like that, and you can start playing those games because it's really as simple as something like that. But my biggest concern was I going to be accurate enough to really diagnose or to rule out that the patient had a concurrent left upper lobe lung cancer? And in my head, I was like, I did not want to be in that situation again, where I said, hey, you don't have lung cancer. And of course, the patient does on the left side, or I, did it backwards and so on and so forth. So I started coming up with these sort of ideas and how I can actually find this out. So I started doing these navigation bronchoscopy procedures where I started injecting certain dyes into the lung to give me a visual aspect to know what to take out. So I went and marked the left upper lobe, and I did a robotic wedge resection. You can see that, there's your, fancy ICG nodule, and all it is really, as a thoracic surgeon, just like we learned in kindergarten, cut around the corners, cut around the lines, and all I did was cut out all the green stuff. And when we looked underneath the pathologist slide, we can see that this patient, of course, in the right upper lobe, my biopsies were easily able to confirm squamous cell lung cancer. And my left upper lobe wedge resection at the time showed caseating granuloma, thereby confirming with over an 87% degree of certainty that the frozen pathology showed me no evidence of cancer, at which time the patient now got staged and he had a right upper lobectomy. So that really saved this patient a lot of time in terms of getting that, what we call the ping pong ball effect, right? Usually what happens conventionally, and I'll talk about this in my lecture as well, is these patients get a diagnosis of, a lung nodule. Then they get referred to, a pulmonologist or a primary care physician or a medical oncologist, and they say, aha, you need a lung biopsy. And so they go and have to schedule that lung biopsy at interventional radiologist, and that takes about 2 to 3 weeks. They get the lung biopsy. The biopsy takes about a week to get back, and then someone follows up on the data a week later and says, oh, you have lung cancer. Let me refer you to someone else. Sometimes I'll bring them to the office, and it takes 2 or 3 weeks to refer them to someone else. It could be a pulmonologist, medical oncologist, thoracic surgeon, at which time someone says, oh, you need a staging. So they send it to a pulmonologist or a thoracic surgeon to get the endobronchial ultrasound or the mediastinal or the mediastinoscopy. 2 or 3 weeks go by, and they say, oh, you don't have any lymph nodes are positive. Let's send you to a surgeon to do the surgery. So you can see how that poses a significant delay in patient care. And we'll talk about why that's really important here. Just for the sake of time, I don't want to talk about the second case. It's just a case, I'll go really quickly, where iron was used to prove that this nodule in the left upper lobe in a patient with a esophageal cancer was not cancerous, and therefore the patient was able to complete his regimen and get cured from his gastroesophageal junction cancer. So this is where we start to really evolve now, and this is where I start kind of put it all together. And so the real reason, at least in my opinion, that we don't have a very good survival rate for lung cancers because in the past, we really hemmed and hawed and waited for these lung nodules to grow bigger. And that was the biggest problem because we see, for example, as our interventional pulmonologist alluded to, you have a patient with a 3-millimeter lung nodule, smoking history, and this nodule, of course, no one's going to say, hey, let's go and operate on a 3-millimeter lung nodule, but they get entered into a pulmonary nodule program, which means that we say to these patients, yes, we need to make sure the surveillance is done on you, and we'll get a CT scan in 3 months or 6 months, depending upon your degree of risk. So if this 3-millimeter nodule grows to 6 millimeters and is spiculated, it's solid, well, that's a lung cancer until proven otherwise. But in the past, there's a lot of surgeons are hesitant to do an entire lobectomy where you take out the patient's entire lobe for a 6-millimeter or an 8-millimeter nodule, because what if it was not cancer? Now you've actually not helped the patient out, but now you've opened up a whole can of worms of complications, at which time we did not help this patient at all. So I really want to see what I can do to move that needle, if you will, and do what we call stage shifting. So this is a case of a 54-year-old male who had an incidentally discovered pulmonary nodule in the left lower lobe. The patient never smoked a day in his life. He was actually an athlete. And he got enrolled in a pulmonary nodule program, and then again, we had a repeat CT scan several months later, and we saw that this pulmonary nodule went from 3 millimeters to 7 millimeters, and it became spiculated in morphology. So here's a CT scan. And again, when you look at the CT scan, most of it looks very normal. What we're really focusing on is on this tiny, tiny, tiny nodule in the left lower lobe. Now, the biggest problem about finding these nodules, and I explain to my patients, is very similar to taking 2 grains of rice and putting it in a pillow and saying, aha, now I want you to feel that pillow, that pillow and see if you can find these grains of rice, or if you can look at a pillow and tell me where the grain of rice is. And of course, that is a very daunting procedure, and we're not going to be able to do it. So I started doing, again, in almost standard treatment and protocol for our patients, we started doing these navigation with dye markings where I'm injecting ICG and Omnipaque directly into the nodule, so now I can visually inspect the lung to see where this nodule is. So we went in and I took it out, I did a wedge resection, again, same thing in kindergarten, take all the stuff that looks green, and I walked over to the pathologist and I said, hey, listen, I got this nodule out here, what do you think you see? So this patient, quite honestly, in my mind, had a very low risk of anything real, right? Maybe at most adenocarcinoma in situ. It was at the end of the day. I still remember, it was about 5:30, and our pathologist had the key sign, right? So she was ready to go home, because I remember her daughter had horseback riding lessons, so she was trying to rush out of the hospital to get home in time. So she looked at it underneath the microscope, and she's like, oh yeah, it's adenocarcinoma in situ. So I said, okay, great. Wedge resection, we're done. So I walked out of there, and I walked back to the operating room. And in my operating room, I actually have this, kind of fancy microscope. This fancy microscope is called Van Gogh, and I'll explain it in a second. But what happens, I looked across the room at the Van Gogh, and I saw this. This is actually I saw this image. This image is essentially the virtual imaging of this nodule I took out, and you can see all these big yellow cells that are lighting up because of metabolic activity. So this Van Gogh system was very integral in having me say to myself, oh my God, I really think there's cancer. So I run back to the pathology office, and Rebecca's literally kind of leaving. I said, Rebecca, I really think I see cancer here. And so she goes, well, what do you mean? So I explained to her. So she goes back to the slide and she looks and she goes, oh my God, you're right. There is invasive adenocarcinoma on the corner of the slide that I didn't see, and so it really changed the paradigm for this patient. This patient ended up with a segmentectomy and, left 2 days later out of the hospital. And again, this patient has a 90% 5-year survival rate because of the fact that we didn't waste time taking this cancer out. Again, You can see how small these cancers are, how they can be misinterpreted even on the day of surgery by pathologists. And with the advent or the incorporation of certain technologies, we were able to save this patient a second trip to the OR. And again, we potentially save this patient, a stage elevation from, delay in care and so on and so forth. Maybe, maybe not. But ultimately, what this technology is that we use also is called the Van Gogh system, and it's a dynamic. It's a microscope that uses what we call dynamic cell imaging. It's a really cool technology. What it does, it actually measures the vibrational activity of certain cells. And so cancer cells, will have more mitochondrial dependent activity. And so by telling these by detecting the vibration, it actually gives us sort of this heat map. So now we can see cells that are bigger and larger than normal cells, i.e. cancer cells tend to be larger, pleomorphic, and they tend to stick together, what we call clumping. And then when they light up, you can see that the yellow cells that I showed before. That gives you a very high degree of suspicion that you have cancer cells, at which time you can enact the proper treatment for these patients. Now, this is really why we do all this, because of the fact that truly accelerating the timeline and the efficiency of diagnosing, staging, and treating cancer is what it's all about. And only by succeeding in doing that are we really going to have any impact in saving these patients. But now, if you look at the current guidelines for addressing what the maximal acceptance of waiting time it is, when a patient gets a diagnosis and referred and so on and so forth, if you look back in January, again, this was introduced back in January 15th, they have determined that a maximum total wait time of treatment is 35 to 42 calendar days from referral to the start of treatment, right? So that's a pretty long time. The biggest problem about that is the fact that when you look at cancer doubling time, adenocarcinoma, the tumor doubling time is about 150 days, squamous cell cancer is about 130 days, we don't know where that 35 days to 42 days is in the growth of that cancer. So if we're on the back end of that adenocarcinoma and it's 1 centimeter, and we wait the 3 months to 2 months, getting these patients into the OR, that patient can double that 1 centimeter cancer to 2 centimeters, at which time they go from a stage 1 to a stage 2. The biggest problem about that is when patients have stage 1 lung cancer overall, we're talking about A, B, C, and D, the A, B, and C, the overall 5-year survival rate for lung cancer patients are stage 1 is about 70 to 75%. When they go to stage 2, the overall 5-year survival rate for stage 2 patients is 45%. That's a huge drop in the survivability for these patients because of the fact that we delayed their care. Now, we didn't delay their care because we did anything wrong. I think we delayed their care because we did not have technology that could really help these patients way back then. So hopefully, by moving the needle, and we do this in 3 hours, we can truly help out these patients and really save some lives here. What do? Well, the first thing I did, I said, okay, I really want to kind of give credibility to what we're doing. So I'm a private surgeon. I hate writing papers, right? And so I really sat down because I really thought this was really important. I convinced a medical student to write this paper for me, and we showed, I did pay him, so that's private practice role, right? But anyway, so we were able to document that it did not matter. In every single case where we intended to get out that nodule, we had a 100% success rate in getting out that nodule to either prove or deny cancer. And this is why it's so important for these patients. The biggest problem, I think, that hinders sort of these patients is there's a certain sort of dialogue that goes on with non-surgical professions. And these guys are saying, well, we saved you from surgery. I think there's a big problem with that. Unless we actually learn to work together with our interventional pulmonologists and medical oncologists, no one's saving these patients from surgery. What we're doing is we are potentially missing lung cancer. Why? When you do a wedge resection on these patients, a surgical wedge resection, that surgery takes us about 15 minutes to do. You take out the nodule. If it's cancer, well, great. If it's not cancer, these patients really stay in the hospital. Sometimes people leave later that afternoon. Some people leave the next day. But the complication rate from a surgical wedge resection is very low. It's less than 1.5%. So we are not saving these patients from surgery. What we're doing is saving them from 5 years of anxiety, wondering if this nodule is truly cancerous or not. But more importantly, if it is cancer, we are saving them from lung cancer. And I think that sort of discussion among the medical community should really kind of veer away from we are saving these patients from surgery. So you can see what happens when we actually combine the technologies of robotic navigation bronchoscopy followed by surgery at the same time. Throughout the years, you can see, for example, in 1 year I did about 60 lobectomies for stage 1. The second year I did another 55 lobectomies for stage 2. By combining these procedures, we're able to more than double the number of stage 1 lung cancers that we resected in our hospital, and that means that's a 200% increase in curing these patients from lung cancer. Because why? Because before this technology, we had just waited. Before this technology, we had just patted the patient on the back and says, I hope it doesn't grow, but come back in 3 months. I hope it doesn't grow, but come back in 6 months. And if it's cancer, if it grows, then of course, then we missed cancer, guys. And I think that's the biggest problem that we have here. So why do I incorporate robotic navigation bronchoscope into our program? Because as we know, lung cancer screening, it does save lives. And again, there's a whole NCI paper on it. But the biggest problem about lung cancer screening is only about 2% of patients in this country are diagnosed with lung cancer via lung cancer screening. As I said, the majority of patients, over 88% of patients, are diagnosed with lung cancer because of an incidentally discovered pulmonary nodule. So this whole push for lung cancer screening is not hitting our community. I don't know why. It could be, access to healthcare. It can be, anxiety for the patient because I just don't want to find out. It could be, a lack of sort of drive from the primary care physicians and saying, hey, you need a lung cancer screening. I don't know what it is, but currently the lung cancer screening program is not effective in finding lung cancers in a patient, and a pulmonary nodule program really is. And so what I really think that we need to use the robotic navigation bronchoscopy system is to decrease the timing and the duration of diagnosis, staging, treatment. And we can all do this if we actually work together on this. Not only the thoracic surgeon, not only the interventional pulmonologist, not only the interventional radiologist. We need to combine our forces like a cardiac program does. The cardiologist and the interventional cardiologist and the cardiac surgeon, they all work together in doing one thing, and that's saving the patient. And until we actually can do this collectively as a hospital system, I don't think we're going to do much in helping these patients. But when we do, we're going to be doing a lot to save these patients. As we know, earlier cancer detection improves survivability. However, I really kind of want to advance this even one step further. It's not lung cancer detection. It's actually lung cancer not lung cancer screening, is lung cancer detection. And there's a difference because what happens in a hospital that only says, oh, you got a nodule, oh my God, the lung nodule is increasing, versus a hospital system that says, oh, you have a lung nodule that's suspicious for cancer, and we are going to do something about this in the next week or two. That is a lung cancer detection program and no longer a lung cancer screening program, and that's what's going to save lives here. This is just a picture of me. I started doing sort of interventional, interventional pulmonology, and I started using photodynamic therapy in combination with ion cases. So, just for the sake of time, I don't want to take over anyone else's time, but this is a patient with a 10-centimeter metastatic melanoma to the right middle lobe. We don't know where his primary is. We checked everywhere, even all the weird spots, the scalp, the eyeballs, the rectum and stuff like that, and we couldn't find where this guy's melanoma came from. But we know that in his middle lobe there was a 10-centimeter biopsy-proven melanoma. So the patient underwent immunotherapy. And the biggest problem with this patient that he did not respond to immunotherapy. Why? Because the PD-L1 receptor status from this patient was very low. So PD-L1, I don't want to get into this right now, it's just a receptor that if you have it, good, immunotherapy works for you. If you don't have it, not so good, immunotherapy doesn't work very well for you. Well, the one thing we know is that photodynamic therapy improves or increases PD-L1 activity in a lot of the pathology specimens that we see. So I thought to myself, hey, as a thoracic surgeon, can I navigate this ion into this 10-centimeter nodule mass now, stick it with multiple sites of the photodynamic therapy and treat with multiple sites, just, with the commercial you saw, we have that cloud-based technology where I can tag different spots on the cancer, and that's exactly what I did. Within 1 month, this cancer went from 10 centimeters to undetectable on a CT PET scan. I then further took him to surgery, did a middle lobectomy on him, hilar lymph nodes. So he had one hilar lymph node that was positive for metastatic melanoma, and he had residual scarring and stuff that they could not see cancer anymore in the rest of his cells. But again, the patient needed, the metastasectomy to be done. So these are sort of like the things that we really need to push with robotic navigation bronchoscopy. It is no longer a diagnostic tool in the right hands. And sooner or later, hopefully, we can start developing protocols to incorporate, pulse electric field technology, photodynamic therapy, injections of certain viruses that increase radiosensitivity to cancers. That's how we start using this navigation bronchoscopy. It cannot replace a CT-guided biopsy. It has to be a treatment paradigm, which you all can help these patients out. So this, again, is another paper from Canada which demonstrates, well, why is it so important to get these patients to the table, right? And so what you can see here is on the curve on the left side of the screen, the dark line represents the survivability of patients who were diagnosed and treated within 30 days. The lower curve represents patients who had treatment after 30 days of diagnosis. That is a big discrepancy between just 1 month of waiting for these patients. And that is why the drive has to be, as soon as we know this nodule exists, it is a race against time to save this patient. We are no longer going to say, hey, listen, if I saw this nodule increase from 3 millimeters to 8 millimeters, I'm not going to get another CT scan. This patient is in the OR getting this nodule out. And how do we find it? We combine technologies. So this is exactly what I was talking about. It's so important to start understanding that hospitals should not call themselves lung cancer screening programs anymore. It really needs to become a lung cancer detection program, and that's what saves lives. If you look here, this is the graph I was alluding to. If you look on the left side, stage 1 lung cancer patients have about 65% to 70% 5-year survival rate. Stage 2 dropped down to a dismal 45% to 40%. Stage 3, stage 3A, we're talking about less than 20% to 30%. Stage 4 is really kind of an unsurvivable disease, although now with the advent of immunotherapy, we are seeing timelines extended beyond 5 years. However, when you actually tease out the number of patients in stage 1, you can see you have your different stage 1A, stage 1A2, so it goes on and on. But if we can actually go and cure these patients and treat them in the stage 1A portion of their cancer lifespan, that is a 5-year survival rate of 92%, thereby increasing it from your overall stage 1 survival rate of 65% to 70%. And this is exactly why I think it's so important to pursue this paradigm of treatment and evolve all our cancer programs, because that's the only way we're really going to make a dent in treating and saving these patients. Thank you, everyone, for their attention. I know I spoke really quickly. I just wanted to make sure I respected everyone else's time. Thank you again.
Questions?
I'll start out. Great presentation, Dr. Tsai. I loved how you think about lung cancer screening and lung cancer detection, and really moving this as a surgeon forward in your practice. And obviously, you're doing a lot of these procedures. My question is, when you see a suspicious lung nodule and you're planning a single anesthesia event, at what point do you believe a negative biopsy, or how often do you see that? Do you versus going just for localization and wedge resection? Because I think the biopsy and the rapid onset testing and things take time. So how do you go about that?
Perfect. So my algorithm is, if a nodule is less than 1 centimeter and is highly suspicious for lung cancer, there are certain things I do. So there are these blood liquid assays that can actually predict the probability that this nodule is cancer. So there's a company, again, not trying to plug in companies here, but CircularGene is a company that I use, and one of their subsidiary companies is called Lung Life AI. And by using certain FISH analysis of the patient's blood for certain proteins, it can actually increase or decrease your suspicion that this lung nodule is positive for cancer. It's a very accurate test. It's over 85%, 87% sensitive. And so if a patient with a 6 millimeter nodule, for example, has a high suspicion for lung cancer based upon the Lung Life AI, that patient's going to the OR. If it's a patient with the low risk for Lung Life AI and it's like a 6 millimeter nodule, yeah, okay, now I feel more comfortable waiting. But again, that doesn't mean this patient falls off the radar. They get their CT scan in 3 months or 6 months, depending upon the morphology of that nodule. And if anything changes with that nodule, I don't care what that Lung Life AI says, that patient's going to the OR. Now, if it's a nodule that's 1.5 centimeters or greater, and you do your robotic nav bronch, let me take a step back. I have actually shifted all my robotic navigation bronchoscopy cases to my interventional pulmonologist. So in the beginning, I can convince one to do it. In my hospital now, I've convinced 7 pulmonologists to do this with me. So now what it's done is jacked up or skyrocketed the number of interventional pulmonology cases for our hospital. And so these guys have become much better than I have in doing the robotic nav bronch. They understand cone beam CT scan to a much better exponential degree than I ever will understand or ever care to understand. So if these guys have tumor lesion with diagnostic tissue that I see on on my Van Gogh system and that doesn't look cancerous, then I'm not doing surgery on these patients. So it really depends upon the tumor appearance and the degree of suspicion for cancer. And quite honestly, also, one more thing that we do is on the day of the surgery, we actually do a CT scan as well. If that CT scan shows that the nodule has gotten smaller or is no longer present, of course, we cancel the surgery because then that's nothing that is going to demonstrate cancer as well. So those are sort of like the algorithms that we do to kind of go to the next step, right? And it's all stepwise pattern in terms of, what the nodule looks like, what the suspicion is based upon certain liquid assays. And of course, same-day CT scans also help guide that algorithm.
Again, Dr. Tsai, outstanding talk, and I want to apologize for the very obnoxious music. Welcome to the French Quarter of New Orleans, Louisiana.
I was trying to talk in cadence to it, so it's like I was trying to rap to it, but it didn't work too well.
Yeah, but I want to compliment you on your comments as it relates to the difference between lung cancer screening and incidental nodules. I wholeheartedly agree that incidental nodules, there's going to have a much greater impact on patient survival, and also the nodule detection to treatment time, the importance of that in survival. And I think it's sometimes difficult to have all of the key stakeholders understand the importance of those two concepts. We've been doing these, we call it the single anesthesia event, going back, I think our first case was in 2021. And we have kind of some relatively discrete inclusion criteria. Our cutoff is anything less than 2 centimeters, no history of solid organ malignancy within 5 years of presentation. Do you have any specific inclusion/exclusion criteria on top of what you've already mentioned?
Yeah, so for us, 2 centimeters was actually too big of a nodule to go after. We really want to see if we can push our program to really increase the percentage and yield for stage 1A lung cancers. The biggest problem about 2 centimeters is now you're really walking that sort of gray line between stage 2 and stage 1, right? And so that's our biggest concern is if we started doing things that were easier to hit with the robotic nav bronch on biopsy, then we were very concerned that we were missing those truly early stage lung cancer. So for example, you have a patient with an 8 millimeter ground glass opacity, right? And we all say, oh my God, it's GGO. It could be inflammatory, it can be granulomas, or it could be adenocarcinoma or adenocarcinoma in situ. So of course, we're not going to jump in and go and do a surgery right away. These patients get entered into our pulmonary nodule program, and if there's any change in that GGO, especially with solid components that's starting to change in it, that is an invasive adenocarcinoma until proven otherwise. I just did one the week before I got here. I didn't want to show it because I'm still waiting for the diagnosis, but this was such a subtle GGO that increased in size, and when we took it out, it wasn't a GGO. It was actually a nodule that you can palpate. And so again, these CT scans might sometimes underread what's really going on in the lung. But we took it out because of the fact that it looked like cancer. I did put it on Van Gogh, and Van Gogh really demonstrated large pleomorphic cells. I didn't want to waste it on frozen because it was so small. And the pathologist was like, well, if I do a frozen on this, I might not have enough for NGS and stuff like that. So I said, it's okay. Let me just, so he did a smear. He took and he says, well, we do have really large cells here, but I can't tell you it's definitely cancer, which is fine by me. Because whatever it is, we took it out, we went through, and we did the right thing. So I really think that it's imperative that if we want to really do anything about the survivability of lung cancer, we need to push the envelope. And subcentimeter nodules definitely fall in the category of biopsying, and if they can't biopsy accurately with robotic nav bronch, then you better be on standby to take this out as a wedge resection. The thing about it is our pulmonologists are getting so good. These guys are hitting 1,000 cases. When they incorporate cone beam CT scan into the room, they will get tool and lesion. The biggest problem about tool and lesion, that does not necessarily mean you have lesion and tool. And that's the biggest problem about saying, well, my needle's inside the lesion, but that doesn't really necessarily mean you're getting the representative sample of that 7-millimeter nodule, which can demonstrate cancer. And that's why if the suspicion is high enough, I actually don't waste time with the biopsy. I say, hey, get me an ICG dye marking. I'm going to take this thing out. Now I got the whole nodule that I'm bringing to the pathologist, and that gives me a much better representation of it's cancer or not. I have not met a patient yet that you took out this nodule and you told them, hey, it's not cancer. I had not had one patient tell me, oh my God, you did unnecessary surgery on them. Every patient will say, thank God you took it out, because now I don't have to be looking over my shoulder for the rest of my life, for the next 5 years, wondering if this is cancer or not. They know it's out, and these guys are the high-risk patients, the big smokers, et cetera, history of cancer in their family. They want this nodule out. And it's the same thing. I don't know of any female that says, well, I have a breast nodule, just leave it in there, let's keep on watching. Every female's like, take out that nodule in case it's cancer. Why? Because the surgery is so minuscule for taking out that nodule in the breast. We need to start believing that the improvement in robotic surgery makes the wedge resection that minimally invasive that these patients will also have no problems taking out a nodule that's not cancerous.
I want to clarify, 2 centimeters was our upper limit. Anything above that.
Okay. Yes, sir. Sorry, I misunderstood.
Thank you, Dr. Tsai.
Thank you, everyone.